All right, good morning. I'm Julie Tennille, Project Director for EPIC, and I'm joined by the rest of our talented team, Wendy Myers, Program Coordinator, Cheryl Neal McFall, Program Evaluator, and Sarah Franciotti, Research Assistant. There's so much excitement about this morning's symposium presenters. We have returning EPIC favorites, Dr. Ebony White and Dr. Sarah Wenger. We were also thrilled and super proud to have an EPIC graduate from our MSW program, Jordan Cunningham, sharing about her integrated care experience. Finally, we are excited to hear from Chris Bradbury and Dr. Sherelle Lockhart on a unique international collaboration. So just a few notes about this morning's event. First, please remain muted. Our presenters will briefly answer questions following their presentations. Those presentations will be in different formats. One will be a video, one will be a PowerPoint deck, and then the other will be sort of a conversation. These questions can be entered into the chat once the presenters are done, and there will be more time around 10:40 to ask questions of all presenters. Second, we want you to log in with your full name for attendance credit. If you need to change your name, click on the three dots in the upper right corner of your personal Zoom window. And finally, and please listen closely to this, if you want CEUs or a certificate of attendance, you're required to attend the entire training, complete the post-test survey. There's not going to be a pre-test survey, and complete a certificate request while the event is still live, so before 11 o'clock this morning. The link will be available at the end of the post-test. So at this point, it is my honor to turn this over to the Dean of the College of Education and Social Work.
Well, welcome all. I am Deisha Williams, Dean of the College of Education and Social Work. I'm thrilled to kick off this morning EPIC Symposium focused on integrated care in real life. We have an exciting collection of teams featured, including one of our own WCU, MSW, and EPIC alums, Jordan Cunningham from New Mars Children's Hospital. So exactly what does it look like when a collection of primary and behavioral healthcare disciplines come together in a team? How do they know how to do warm handoffs and are collectively committed to better outcomes for kids in different settings? You are about to find out. The EPIC team, led by social worker professor Julie Tennille and MSW alum Wendy Myers, have managed to excite the interest of hundreds of regional attendees over the last several years for this continued education events focused on integrated care for children, adolescents, and transitional-aged youth. So settle in and get ready to learn how integrated care shows up in real life. Unfortunately, I'm not able to stay, but no, your time is going to be epic. Thank you.
Great. Thank you so much, Deisha. All right, so I am going to share the first video presentation of Dr. White and Dr. Wenger.
I am an associate clinical professor. I'm sorry, I can't hear it, Julie.
I can't hear it. All right, let me see if I can fix the volume.
Julie, it started out okay and then it cut out.
Okay.
And my practice is primarily black and brown. Brown folks, but a pretty big mixture from.
Is that any better?
from all over the place and all over the world. And I treat a pretty wide age range, but that does also include adults in transition and some teens.
And so Dr. Wenger and I have had the pleasure of working together at the Stephen and Sandra Scholler 11th Street Family Health Services Clinic in North Philadelphia, with wonderful community members, wonderful patients. But today we're going to talk a little bit about collaboration, this wonderful Collabo, and how to do it. And I think it's important to talk about kind of our philosophy around our different professions and our philosophy around the roles we hold and the clients that we serve. And so, Dr. Wenger, do you want to start?
Sure. I think sort of how I ended up treating in this patient population and treating in a pro bono setting. So the whole clinic is not pro bono, it's a federally qualified health center, but the physical therapy services specifically are pro bono. I don't think that I entered my career and that's what I walked directly towards and that's what I was going to do, but I certainly gravitated towards underserved diagnoses, underserved populations, areas that were under-resourced. I felt like I wanted to be helpful and of service, and that idea of like competing, treat the best athletes or something like that was never appealing to me. I always sort of, well, let me go over there where there seems to be a gap. And I think that I fell into it because I was sort of naturally attracted to going where I felt most useful. And I think over the years, working with populations who are under-resourced and underserved, I've really enjoyed it and I've gained an appreciation. And I think I've gained some skills in working at 11th Street where we have a lot of discussions about who we're serving and what's going on in the community and what are those reasons behind being under-resourced. And that has been just really helpful in informing my practice and being able to show up in the way that I'd like to show up for my patients. And I also very much enjoy being holistic and complexity and things that aren't necessarily following the textbook. And it just feels like a really good fit for me. And I adore my patients and I adore my colleagues.
Absolutely, it's interesting. I think we share a similar philosophy. I think, some folks come into our fields or to any field and they look toward the plateau or the success of it, like what they can gain from it. And there's nothing wrong with that, right? We live in a society that values competition and going to that next step higher and higher and higher. But I think that when you're serving the populations that we serve, you're already a person, or I was already a person that noticed, like you said, the need, the necessity, or the gap, right? And it's like, wait a minute. This is happening over here, but what's going on for these folks who also need these services? And I know a lot of that has to do with my background and my upbringing and where I come from and my social location and all of those things. But at the same time, I feel uniquely situated, having come from a certain background, but now being where I am in life and feeling a pull and a responsibility to make sure that I am serving the people who most need to, or who I feel most needs to be served. There's a quote, we were talking about it the other day, that I wanted to bring in today by Patricia Hill Collins. And she says that oppressed groups are frequently placed in the situation of being listened to only if we frame our ideas in a language that is familiar to and comfortable for a dominant group. This requirement often changes the meaning of our ideas and works to elevate the ideas of dominant groups. And that really speaks to me because I noticed how so much value was placed on white standardization, right? On fitting this mold that really didn't fit the people that I served, that really didn't fit me or my family and friends either. And I found that the more we tried to explain that plight, the more there was miscommunication and the more misdiagnosis occurred and the more problems that occur because folks weren't allowed to speak from their vantage point, from their perspective, from their own cultural space to get the services that they need. And so my philosophy is that the provider needs to communicate in the language that is most dear and most centered to the population that they are serving. And I'm not just talking about the speaking language, right? The verbal language. I'm talking about body language. I'm talking about maybe dismissing some ideas around distance in healthcare, right? And that maybe we need to get closer in healthcare to one another, right? I'm talking about bringing in spirituality all the time because it's so important to the populations that we serve. And so my role is as a servant, right? To serve the people that are important to me. And sometimes serving looks like a real humble thing when I'm working with clients. And sometimes I look like a bully when I'm in other spaces where I'm fighting for my clients, right? And so that's that's important as well. But to segue to the unique needs of the population, if we're specifically talking about adolescents, young adults, we have to talk about the multiple layers of oppression that occurred. I know you've seen this, Dr. Wenger, right? We're talking about race, economic, and then age, right? Where we already look at people as not knowing or not being competent enough to explain their needs or to know what's good for them. So what are your thoughts about that?
Yeah, so I'm going to back up just a little bit because I have a different social orientation and a different history than Dr. White does. So I can't come to my patients from a place of sameness, right? I come with a really different life experience. And I agree that it is also important to meet people where they are. But for me, I also think that it's really important for me to show up as my genuine self, because engendering trust and engendering communication, right? You can't communicate well and you can't engender trust if you aren't being your genuine self. So for me, I am going to speak like I speak. I'm going to be who I am. And I'm going to make a lot of space for my patients to do the same thing, even if that is not the same as the way that I communicate. So I think it's important. And I try to teach this to our students a lot. You don't have to be the same as your patients to be able to be understanding and provide good care. I think it certainly goes a long way and it helps. And there's a mountain of research to support that. But I think it's completely possible to show up and be a good provider and engender trust, so long as you are making space and, again, not requiring that code switching type of communication, that you are able to hear someone as their genuine self, right? So I show up as my genuine self and I leave space for my patients to do that. And I, try to hear them as they are and make that make sense without me introducing a bunch of narratives, with me just listening to who that person is and holding compassionate narratives towards my patients. So relative to youth populations, I do see a lot of young adults, and I think they are, there's this unique thing about youthfulness where, oh, you don't know what you're talking about, or, oh, you're young. And I think that's a narrative that we see about youth a lot. And so I think that also extends to youth. I always tell my students, your patient's the only one inside of themselves. I say this to my patients a lot. You're the only one inside of you. You can string however many letters you want after my name and make me as smart as you want to make me, and I'm never going to know, what it feels like inside of you. So when you explaining to me how it feels or what's going on or what you can and can't do, those are all things that right? And that's how we partner to figure out how to get you feeling better.
Absolutely. I think most important for me is to recognize that the youth values may not be the same values that I have. So even if I'm coming from a place of sameness, we may look alike and have similar backgrounds, there are generational differences that result in different expectations, different desires. And so that's important to note as well. And so as we start to wrap up, it's important for us to talk about collaboration, what prompts it, what makes it work, and how does it change our practice? And so for me, the first question is super easy. What prompts collaboration? I find that with my clients, they sometimes don't even realize the things that are accessible to them or the options that they have open, right? And so if I mention something like physical therapy to them, they're like, what? So really it's about bringing in options to the room. Although I'm a therapist, I'm a clinician by trade, when I'm listening to my clients, they're whole people with not just mental health needs, right? And so if they're saying things that are beyond my scope of practice, then that clues me into, okay, a referral probably needs to be made.
Yeah, and fully agree with that. And I think being on one of my important roles on the physical side of things, making a referral to mental health is also to offer a lot of destigmatization, because when you suggest mental health, that can go off not well. That can land poorly on your patient, and they, oh, what are you calling me crazy or something? So I think when we make mental health referrals, particularly, they really need to come with destigmatization and really an explanation of what mental health has to offer and how it can be helpful and how it's been helpful for patients in the past, and really, supporting mental health colleagues in that referral and setting up like positive expectations around that, and reducing some of the anxiety, fear, and stigmatization that can be associated, although I'm noticing it less and less, happy to report. So I think that's an additional, and then all the same things that Dr. White said, where, once we're getting into areas where I'm not trained, if I'm working towards goals and some of the barriers to those goals are anxious behaviors or depressive behaviors or familial dynamics or lack of resources, those are all things that I'm not necessarily the trained person to help with that. And I think that's where referrals are really helpful.
Absolutely. And you made me think of something before we talk about what makes it work. Sometimes the referral isn't a literal referral to a provider. Sometimes it's bringing in someone that's close to the patient or the client to help support them as well. So that could be a community resource, that can be a family member. And so that's important as well. And so thinking about what makes collaboration work, two things come to mind for me. Number one, taking ego out of it, so making sure we remain client-centered. I've seen a lot of treatment teams or people trying to work together, and everyone wants their voice to be heard, or everyone wants to feel right, and lose sight of really why we're there and being client-centered. And then the second thing I think that makes collaboration work is those, I think you call them warm handoffs, right? So when you have a relationship with the other people that you may be referring clients or patients to, or that you're working with the client as well. I don't know, what do you think? Are there other things I'm missing?
Yeah, I think the warm handoff is so helpful. And I think just communicating, right? So Dr. White could treat someone and I can treat someone, and if we're not talking to each other, is that really what interprofessional care looks like? Sure, that patient's being treated by multiple professions, but we really want it to be coordinated and streamlined so that patient doesn't feel like, they've got this happening over here with their doctor, and this happening with their PT, and this happening with their mental health provider, and this happening with the specialist. And they've got all these separate plans happening, and it's sort of on the patient to figure out, how do these things overlap and coordinate? How do I prioritize? I think real interprofessional care is when the team is getting together with the patient and any other important stakeholders, family or whoever else is important in that unit that is the patient, and help, coming up with something that feels like one plan of care towards a patient's health. So that, I think, requires a lot of coordination and communication on the part of the different providers with each other and with the patient. And I think one of the big characteristics that's important is, feedback receptiveness. I think Dr. White was speaking to that. So if I'm getting feedback from another provider that a patient's uncomfortable with what I'm doing, or, I'm a physical therapist, the gym is busy and loud and there's music and people, and sometimes that's uncomfortable. And I need to be able to receive that information, without defensiveness, and really work towards something that works better for my patient and not be focused on what's more comfortable or working better for me. And to me, that's professionalism, right? We move to the patient. We don't make the patient accommodate us. We accommodate them.
Absolutely, we accommodate them. And so lastly, you and I both know that collaboration changes the way we practice. And I think the biggest piece for me is that clinicians in the mental health field, we tend to think similarly when it comes to treating, right? And so I'm educated or indoctrinated into a certain way of thinking and seeing and assessing. And I'm always blown away by how much I learn when I'm collaborating with my colleagues who enter into these conversations in a very different way. And it really opens up my mind. And even though we may be working with this one client together, what I'm learning from this collaboration influences how I work with my other clients as well.
Absolutely agree with that. And I think I've gained a lot of skills working with mental health providers in particular, because I think it provides information about a specific patient, like what might be a better approach for engagement, what might be a better approach to create comfort. But then again, I can use that moving forward. And I appreciate that collaboration a lot. I think when I'm collaborating, I feel like I'm a better PT.
Absolutely. Well, thank you, Dr. Wenger. This has been fun.
Thank you, Dr. White, and thank you, all of you.
Okay, wonderful. Thank you so much to Dr. White, Dr. Wenger. That was lovely and so interesting to hear about your collaboration. I definitely have some questions, but I want to make sure that our group is able to ask some questions of our presenters. So I'm going to look to the chat and invite people to ask a question of these two. What do you want to know? It's sort of obvious to me as I watch them together. And I think this is like the third time that we've enjoyed their presentations, that they have this sort of like thing together. There's some special synergy. And, you know, Wendy and I have talked about this before, but we always kind of walk away with something interesting. One of the earlier presentations that Dr. White and Dr. Wenger did, I think, Dr. White, you mentioned that resilience is sort of a placeholder for social justice, and that just hit us in the guts. And, you know, I had always had sort of a, you know, problem with the concept of resilience, but I really thought that that was profound. And we've sort of, you know, considered that, thought about that. And I've talked about that with some of my classes here at Westchester University for sure. I'm looking to see if there are questions in the chat, and maybe folks are saving them to the end. But I also kind of noticed today that you mentioned, Dr. White, just sort of like this white standardization you talked about. And I hadn't heard that before. I've, you know, obviously heard about white supremacy, and just thinking about that as another way of framing sort of this impediment to communicating with our populations, you know, adolescents that are, you know, Black and brown, that have, you know, economic barriers. And I think my big question to you two is just regarding your collaboration outside of this, you know, dyad that you have. What's it like with your other colleagues that are from different professions? Dr. White, you said that you learned so much from other colleagues, and I'm curious, you know, is there another profession that you work with that you could talk about a little bit?
Absolutely. Well, Sarah, Dr. Wenger, and Sarah's my homie, so it's Dr. Wenger and I, we have the privilege of working, or I had the privilege of working at 11th Street. And so that involved a lot of different entities, right? So in one building, we had primary care, dental, physical therapy, behavioral health counseling, creative arts therapy, Reiki. I mean, and I know I always miss, nutrition, right? We have all of these entities in one building. And so we actually have the opportunity to work with all of those entities. And I learned from every single one of them. And also, even when we think about terms like trauma-informed, recognizing that people may know what that means like up here, but they may not know what that means in action. Right. And so we're saying we're this trauma-informed practice, and people are like, okay, yeah, we're going to be nice to everybody. And then when you say, well, really, this is what trauma-informed means, they're like, wait a minute, can we talk more about that? And what does that look like collaboratively? And so, yeah, I think that I already know who Dr. Wenger is going to say she learned a lot from, so I won't say them. But I think in the primary care setting, I learned a lot from them, because as a behavioral health clinician, I get to determine how long I'm meeting with my clients, whether I meet with them for 30 minutes, 45 minutes, 60 minutes, 90 minutes, 2-hour sessions, right? I can schedule my clients in any way that I choose to. But in primary care, they were talking about how they are limited and they can only have 15-minute meetings or 20-minute meetings with their patients. And so how are they to enact, trauma-informed practices? How can they be genuine? How can they, eliminate distance in that short amount of time, right? As they are working with their patients. And so rethinking the practices that I use when I'm sharing how maybe they can transform their practice as well. I can't approach them from this level of, oh, you have all day to be, to enact this with your patients, knowing that they really don't. They have this really small snippet of time. But I'll pass it to you, Sarah.
I think honestly, it is having that whole team that I feel like's been such a great learning experience. I think, working with our nurse practitioners gives me a much better idea of what's going on with somebody medically. And obviously I'm asking people to exercise. So having a sense of, what they can physically handle is really important for me. I do think that my biggest growth has been in working with my mental health colleagues. And at 11th Street, we have mental health providers who are meeting with people regularly, but we also have mental health providers embedded in primary care who can do like urgent visits. So if I have somebody in physical therapy who discloses trauma or becomes upset or could use some support that I feel like is beyond my skill sets, those folks in primary care, those social workers in primary care can typically come up and like collaborate with me. And so I've learned a lot just by sitting in the same space. And then probably my biggest growth, I think, has been in our we have a chronic pain group. So in that chronic pain group, we have a variety of we usually have somebody from primary care, at least one person with a behavioral health background, and often more, and then myself. And when we first started that group, we were all in the same space at the same time. And just watching how everybody else was operating and giving advice off of each other, and really having the opportunity to observe my colleagues working towards the same goal that I was working towards. I think I really honed a lot of skills doing that. And I got to give a shout out to Dr. White, who's really been an incredible mentor. And she had mentioned, what does trauma-informed care look like in action? And I think that Dr. White, you're such an incredible advocate for that, and such good advice, like really walking through the pragmatic, like what does this look like in this particular situation, baby step by baby step by baby step, and having that kind of mentoring has just been incredible. So a lot of credit to you.
There's that relationship again. All right, looks like we have a couple of questions in the chat. So I'm going to scroll up for a second. You mentioned the generational background of clients. How do you all work to connect with young adolescents these days?
My answer will be short. I feel like I am an adolescent. So I think that's how I could connect with them. But really leading with interest, shared interest, like what kind of music do you like, allowing them to, use slang, allowing them to teach me things, right? I feel like a lot of young people today speak in code, right? Those like LOLs and ROT, like all those things. I'm like, you got to tell me what some of this stuff means, and then I'll communicate with them in the way that they communicate. But a lot of stuff I just already know by being in tune with my community, right? Like I grew up in the hood, my clinical practice, I work primarily with adolescents. I have a lot of little cousins. I have 8 godchildren, right? And so I'm kind of, I know what's going on. And so when I talk to them, the way they speak, oftentimes I'm using that type of language anyway. And I think it maybe engenders, even if it doesn't engender trust, it helps build relationship, right? That they feel understood, or that they can curse in front of me, right? And I won't judge them. And things of that nature.
Tapping into our adolescent selves.
I think Sarah was going to respond too.
Go ahead, Sarah.
Typically, when I'm seeing adolescents, they are often coming with a parent. And so I echo everything that Dr. White's saying, but I'll add, it's, speaking directly to the kid and not, or to the adolescent and not to the parent who's usually telling me a whole lot of information. And often that adolescent is looking to the parent, like, when was the last time you saw the doctor? Mom, you get that kind of response. So even though the child sort of the adolescent's referring to the parent, and the parent is giving me information to also to still direct my communication to the adolescent, and also to get some time alone, I think, without the parent. And parents are pretty good about like, I'm going to leave now and let you do your thing. And so just like inviting a lot of engagement. So it's not just, oh, my mom came in and did the talking and I'm just going to sit here, so I think being very inviting around that.
Nice. Just really, really reaching for that. All right, let's see. So there's another question. Have you been able to integrate services beyond the building when the needs of the client and family surpass the expertise of those co-located? What does the referral and integration of those services look like?
I can take that one. We do collaborate a lot, particularly with specialists. I mean, we don't have any specialists in the building. Well, we have a couple, but not a lot of specialty services. And sometimes it's awesome and it's smooth, and you reach out, you call, you get a conversation, everything's great. And sometimes it's clunky. I mean, our healthcare system around communication is not fabulous. There's no denying that. So sometimes I have patients who are seeing specialists, and I'm calling and I'm leaving messages and I'm sending reports, and it's very hard to get in touch. I have I try to really form collegial relationships with people who refer to me. So, I mean, I have collegial relationships inside the building, but I have referrals from the city and from other places, and I do my best to form relationships there, make sure they have my cell phone number, that they have my email, that communication's easy. So we're not going through that whole, like, press 1,000 buttons, sit on hold, kind of phone systems that are such, there's such a barrier. So I do my best to form those relationships, and partly I do that just by calling and being available. But I've also, for people who refer to me a lot, I try to do like, hey, let's do lunch. I'll come by, I'll do an in-service, just something to put a face with a name, and where I can sit there in person and say, hey, you have a question, call me. I'd love to have all your contact information so we can call. And then just hearkening back to, being a good communicator is explaining what's in my head to another provider in a concise, efficient way where nobody cares what my little PT things are. Like, you don't care what somebody's range of motion measurement is, or you want to know what their issues are. So making sure that I'm not like drilling too deep into my PT specific things when I'm communicating, that I'm like getting to the take home points without too much detail. And then also I'm receiving information and being a good listener.
Great. So I'm going to check the chat again. Any other questions for our...
So I saw in the chat, someone asked, what is trauma informed? And so I will address that. And so plainly put, oftentimes in the medical model, right, we approach people trying to figure out like what is wrong with you. And trauma informed asks you to ask a different question, not specifically out loud, but when you are approaching a patient or client, what happened to you, right? Because we believe that people come with us with a myriad of experiences, and we have to make the presumption that people have experienced trauma in their lives, especially with the populations that Dr. Wenger and I work with. We know that they have experienced trauma in their lives, even if it's not that more specific trauma such as assault or abuse or things of that nature. We know they've experienced racial trauma, they've experienced economic trauma, right? And so knowing that they come to us from those contexts, there's a certain gentleness that we need to approach our clients with. There's a certain level of patience and grace and understanding, right? If our clients are coming in very tense and yelling and cursing, and they may present as aggressive, is that really aggression, or are they leaning into the behaviors that have kept them safe, right, within the spaces that they, and so being able to not take things personal and stay in a relational space with with the people that we're serving. And then Julie, you mentioned something earlier I wanted to go back to. You said that you hadn't heard of white standardization. And so that happens in multiple ways, but the two that I'll talk about is in our educating and learning, right? We know that the standards of practice are centered around folks who are white and typically white middle class, right? Like all those standards haven't really been centered around people of color or people who are in low SCS environments. When we think about when we send folks to the nutritionist and the nutritionist give them a plan and they look at the foods on there, like they can't afford those foods. So they're not thinking about the populations that we serve. They don't have them in mind. And the other way it happens is in the way that we feel like we have to present ourselves as providers to our patients, right? I talked about distance in the video. We feel like we have to have these these really strict and rigid boundaries with our clients. We feel like we have to speak a certain way. We can't talk like ourselves. We can't share of ourselves and really get to know our clients. When there's something, once we get to know our clients and our patients, I know people use different language on this call, but once we get to know our clients, we may learn something about that story that is very relevant to the care that we're providing that we wouldn't have learned about if we had those boundaries in place.
Yeah, and I think I want to circle back to this in the Q&A at the end of the morning, but I want to get back to even your reference to spirituality, getting closer maybe a little bit more. I think that's really interesting. Your discussion about humility and also, kind of becoming sort of that bully when you're fighting, advocating for a client. I think those are really interesting, and I'd love to know how that shows up. All right, so we are at 9:40. So thank you, Dr. White. Thank you, Dr. Wenger. Always wonderful to be with you, and I'm glad you're going to be hanging out a little bit longer. So I am going to now attempt to share Jordan's slides. And again, Jordan is an alum of our MSW program here at Westchester University, and also an alum of the EPIC program. So had training for a year in integrated care and took the elective course on advanced clinical practice and integrated care. And Jordan is now at Nemours Hospital and made us a slide deck and spoke over it to share about one of the specific experiences that she's had, and it's really lovely. So I think the key before was that I muted myself, and I think I need to stay not muted to share sound. So let me share Jordan's.
Remember when I was little, and I always heard things like there's power in teamwork, there's no I in team, or unity is strength. These things were instilled in us to be able to work together, to be together, to thrive together. We see it in the research, we see it in the numbers, we see it in the data that we collect. Teamwork works. And not only do those working together on a multidisciplinary team or an integrated care team profit, but the outcomes for patients, clients, and consumers do too. A previous patient's family stated, "The power in this team have moved us to be more than okay in the most difficult time of our lives." From working with the medical teams, constant communication from 5 different specialties, child life specialists bringing us comfort items, social work supporting us at bedside, working through insurance claims and denials, to helping limit financial burdens, to the care and the grace of the nursing team. We could not have gone through it without all of these people working together as one. So, the integrated healthcare approach describes a shift in our system from a narrow model of acute care targeted at the individual to an overall wellness of the broader population. Right now, we know that research shows that the cross-sectional collaboration between members of a multidisciplinary team enhance patient follow-up, it improves health outcomes, as well as reduce the duplication of services. Interventions identified in a multidisciplinary team include promoting health education counseling, educational materials that can help the prevention and management of different diseases, advocacy for health-related laws and regulations, and the launching of healthy community initiatives that include the collaboration between medical providers, behavioral health specialists, advocates, and those in the nonprofit sector. Interestingly enough, research also shows us that the integrated care approach has saved commercial insurers, Medicaid, and Medicare approximately $26 to $48 billion in the United States from helping and assisting with work around preventative care and social support. That's all the research that I would need. But it goes on to say research is showing the difference that different roles have on the integrated care team, such as care coordination in primary care offices. It led to a significantly higher rate of medical outpatient appointments, for well checks, preventative care. Also, psychiatry on integrated teams quadrupled the number of individuals connected to psychiatric and mental health services in the outpatient setting. Case management interventions led to higher access to medical appointments and developmental services with increased involvement of families for active decision-making. Integrated care has improved early detection of mental and physical health problems. So we can see that integrated care is multifaceted. It could be used for so many different things and in so many different settings. It could be used in the inpatient setting. It could be used in the outpatient setting. For our case study, Leah, her integrated team was both inpatient and outpatient. She did spend 2 years in the United States, so some of the details in the case study have been taken out just for the sake of time, but the case study does grasp the majority of her integrated care team. Essentially, Leah was a 15-year-old female. She resided in Kingston, Jamaica. She was unfortunately diagnosed at a young age with autoimmune hepatitis, which is liver failure. Her liver began to decline dramatically and pretty quickly at the age of 14, and her physician in Jamaica decided it would not be a good fit for her to do the transplant in Jamaica, as they weren't equipped with the resources and they had no knowledge of doing transplant on pediatric patients. So he had reached out to a surgeon in the United States and discussed her case, and we felt it would be a better fit for Leah to have her transplant in the United States. During that time, the family went to the embassy. They obtained visas to be able to stay in the United States temporarily for medical reasons. And during that time, her father began medical workup to see if he would be a fit for living donor. The family arrived to the United States in August of 2021. Upon arrival, Leah was a direct admit to the hospital. She underwent transplant evaluation by the treating team, and she underwent a psychosocial evaluation by a social worker. She was deemed a candidate for transplant. She was listed on UNOS as per policy, and her father continued testing to be a living donor. So you can see that even before transplant, Leah already had quite an abundant integrated care team. Leah and her family are first and foremost the most important aspect of that integrated care team. But anybody who had helped them get to the United States, to get them to the hospital, and to get them to transplant surgery was also a part of that care team. Upon further testing, her father was a match, and both of them went into surgery at the end of August of 2021. Following transplant, Leah was admitted to our pediatric intensive care unit, where her surgery was further complicated, which included becoming catatonic with psychosis. This was a really difficult time for the family. Leah had gone back and forth to the OR about 3 times in one day. Mom needed a lot of social support and needed help as she had no other family in the United States to help her. And father was also still recovering from his surgery. So it was very hard for the family. She spent about 2 months in that ICU, and she was continuously in and out of surgeries. She was able to be admitted to a general pediatric floor following that ICU stay. She still experienced complications, but she was able to be discharged by the end of December, early January 2022. She went over to the Ronald McDonald House across the street, where we continued to monitor her. She was in and out of the hospital a couple times within that time, but she was ultimately able to go home to Jamaica in July of 2022. Almost 1 year after arriving to the United States for that initial surgery. So Leah returned back to the United States in October of 2022. She came for biopsy and to complete all of her follow-up appointments. It was during this time that it was determined that Leah's hip bones had been deteriorating due to the side effects of the medication. We obviously can't stop the medication because it was an anti-rejection medication for the liver transplant. So we had a very large discussion with all of the teams. It included our transplant team, our orthopedics team, our surgery team, to determine if a double hip replacement would be appropriate given her age, that the family's so far away from home, and that the recovery time could be a significant amount of time. Our orthopedics team ultimately decided that it would be more beneficial to do a minor procedure to help the hip bones heal where they are rather than do a double hip replacement at this time. They wouldn't be able to do this procedure until January of 2023. So at this point, the family had asked if they could go home for Christmas and return the second week of January. Unfortunately, as our year came to a close, our budgeting did as well. We weren't able to fund the family to go back home to Jamaica and come back. Mom had to reach out to relatives and she started a GoFundMe page, all of which were included in the integrated care team. They had all helped to support the family during that time. Leah came back in January 2023. She underwent the procedure. She did very well, but she had to learn to walk again. So we added rehab to our integrated care team, as well as the physical therapist and occupational therapist to help in that healing process. During this time, Leah was also given a Make-A-Wish. She decided that she wanted to do a shopping trip, and she got $4,000 to go to the mall with her mom and her brother. And her first purchase was her very first iPhone. So there are certainly a lot of barriers to the integrated care team approach, including funding for staffing and small practices, the continued need for additional research and data to support the cost effectiveness of integrated care teams. There's deficiencies in training, lack of education, or understanding really around integrated care teams. So working on this team, what we learned is that it takes a great deal of communication with all of the teams together. We had coordinated this by doing meetings on Monday mornings to discuss her care, Leah's length of stay, what it looks like, how we can help, how we can support. We also did meetings every other Friday with the Ronald McDonald House to discuss the length of stay, how they can help and support the family. We also did huddles every morning when Leah was admitted to the hospital with the inpatient team. In addition, we held family provider meetings with mom. So mom would get a chance to ask questions, to ask for support, to discuss what she needed. We also worked really hard to define the roles and responsibilities of each team member. Working with a team that large, you can kind of get lost in lines of boundaries, doing jobs that may be somebody else's jobs, doing jobs that are outside of your scope of practice. So we worked really hard to define those roles, the responsibilities, and we really made sure to respect each other's roles. We prioritized Mother and Leah and their needs first. And we would ask team members to reach out accordingly based on what the family needed at that time. Unfortunately, in June of 2023, Leah had spiked a fever while she was at her home in Jamaica. Mom had noticed the fever and brought her to the local emergency room. However, the care providers there have limited knowledge and resources on how to help a transplant recipient with a fever. That can look very different from a regular pediatric patient with a fever. Her care providers in Jamaica had called up to the United States and had asked for her surgeon. However, by that time, Leah's heart had sang its final tune, and she was put to rest in July of 2023. We see that in Leah's case, the importance of an integrated care team. With the family being 1,500 miles away from home, the family not only searched and traveled countries for medical care, but needed so much emotional support in addition to that. Leah and her family had psychology appointments during her time in the United States to discuss being away from home, friends, family, school, having a medical condition, living in a different country, and there was definitely a lot of culture shock. She also hated American food. She would want me to say that. We see the bridge between medical and behavioral care, and the role of the integrated care team has become widely researched internationally. We know that integrated care can be transformational in the lives that we serve. The American Psychiatric Association shows that children and young adolescents diagnosed with one chronic physical illness is 62% more likely to be diagnosed with a mental health disorder. Additionally, 70% of people receiving behavioral health care have or develop a coinciding medical condition ranging from insomnia to migraines to diabetes. It's safe to assume that in Leah's case, she was diagnosed with mild anxiety and depression. With the help of psychology and social work on the integrated team, it helped Leah to be more comfortable in the hospital setting and at medical appointments, utilizing coping skills and becoming more independent in her medical care. We worked together to sort through Leah's symptoms. At times we had discussed were they more psychological or were they more medical. We worked together to ensure that the family always had what they needed to cope with the medical side of things, the emotional side of things. And it goes back to saying that the most important aspect on this team was communication. The integrated care model has been shown to be proven effective, but there's still so much more research that needs to be done. I am a proud Westchester University alumni and EPIC grant recipient. Both have allowed me the opportunity to look further into integrated care and its importance on both my professional and my personal life. While now working at Nemours Children's Hospital, I value and respect the integrated care model more and more every day. This is our lifeline. If we did not have integrated care, the hospital would not flow. We would not have patient satisfaction. We would not have staff satisfaction. We work together as a team because we were taught that teamwork works, and it does. I have held a position as both an inpatient and an outpatient social worker, and in both areas it's so equally as important and it makes an impact. I would not be able to complete my work without the help from my integrated care team.
Thank you, Jordan. What a great presentation. And wow, so you sort of were able to come through this program, graduate, and get a truly integrated care role as a social worker at Nemours Hospital, which I think a lot of students who graduate from our EPIC programs would have loved to do. I don't know that it's, this is a very, complex story. It's a sad story for Leah. And I know that's not her real name, but you worked with a family and just multiple different professionals. Please, everybody, type in some questions for Jordan. What do you want to know about her experience working on this kind of enormous team with capacity for including different kinds of professionals? What do you want to know from Jordan? Yeah, so Erica. So Erica asks, was language a barrier? And if yes, how did you negotiate that? How did you handle that?
So there wasn't actually a language barrier. I will say it was, if mom was speaking to me over the phone, it was sometimes difficult to understand what she was saying. But we just worked through that and she understands. There were times where she was like, I don't know what you're talking about, or I don't know what you're saying. Like that's a cultural thing. So it wasn't really a language barrier. It was more when we would go to talk about things, she was like, I don't know what that means here in America, or we don't do that in Jamaica, different things like that. If there was a language barrier, the hospital does have interpreters that we would just continue to use throughout their stay.
Got it. I like that you said something about how Leah would have wanted you to say that she didn't like the food. And it sounds like you got to know her well. And I guess I'm curious, there's always, especially in hospital settings, there are these hierarchies that emerge, right, with different professions. And I wonder, Jordan, like how you experience a hierarchy at the hospital. Don't have to get into it if you don't feel like it. This is a recorded training. But how is that navigated? You talked about like the difference, the different kinds of roles that people have and the boundaries. Sometimes, you know, it's not clear who does what. How do you define your roles? How is that done? How do you feel it's done?
It can be difficult. I think in this case particularly, there were so many moving parts between, you know, we got communication about her condition, I want to say the last week of July, and by the second week of August, she was here. And that's very unheard of between obtaining visas from the embassies and flying her here, getting the funds to fly her here. It was really quick, and we wouldn't be able to do that without each other. And we knew that. So sometimes it can go a little bit, you know, the other way. But in this case, we kind of really knew that we needed each other to count on each other. Everybody had their roles. Everybody knew that we had to work together to be able to get them here. And she was declining pretty quickly. So, you know, I think it was the surgeons here in America that said, like, we need to get her here. And what does it take to get her here? And everybody just kind of fell in line and did their roles and did what they needed to do to get her here. And
So
then that flow kind of continued as she was here, was just we need to support the family. They're a very long way from home. Mom also had, when they first came here, he was 6 months. And by the time he left, he was a year and some change. So, you know, how do we support mom? She was breastfeeding. You know, we need to make sure that she eats. We need to make sure that the patient eats. How do we do that? So there was a lot to it.
yeah, it sounds like such a complex presentation. So Wendy asks, you know, about the integration of the patient and family. And I think you have talked a little bit about that. Do you want to say anything more?
Yeah, I think it's just making sure that they are priority. You know, there is some culture differences. There may be some spiritual or religious differences too regarding medications or surgery or, you know, all of that stuff. So it's just really honoring the family and their wishes and being able to work together to come to either a conclusion or, you know, to help each other get through that and how we can do that with the family's respect.
And then another one of our attendees said, or asks, outside of the story, how do you handle providers who do not make the time to truly work with the IDT team? Is it IDT or integrated care team? What advocacy tips do you have?
I think it can be hard because we kind of talked about that hierarchy, and there are, you know, people that may say, well, that is your job and you should do it. And it's really forming those boundaries to say, it's actually not my job, but here's how we can work together to make it work. I know at the end of the year when our budgeting closed and we were trying to fly the family back home so that they could go home for Christmas, and that's something that everybody wanted. We wanted the family to be home for Christmas. She already had spent Christmas last year with us. You know, we wanted that for the family, but there was nothing that we can pull from funding wise to do that for them. So I think there was a lot of back and forth about that. There was people that said, well, I'll just pay out of pocket to fly them home. So it's making sure that people maintain their boundaries too and advocating for the family at the same time. And it's difficult. It can be difficult at times.
And another attendee asks, you know, what do you do when there are team members who don't agree on situations? How's that navigated?
We, at the hospital, we would have meetings, and it's all about just kind of breaking down where the miscommunication is maybe, or where we can compromise on things. That can be difficult as well. People have their opinions and they're very strong in their opinions at times. So it's either going to come to a compromise or it's going to say, you know, this is what's in the best interest of the family, and really making sure that the family's first and foremost what we're thinking about, not our agenda, what we think is right. And sometimes we would pull mom into that and say, what do you think about this? Here's what we're looking at, and allow her to make that decision, you know, appropriately and accordingly. But it's really making sure that we're putting the family first.
Nice. And how did you manage any possible biases on the part of the medical professionals? Very different from behavioral health professionals. And Ashley also works in a healthcare or hospital setting and often finds that she plays the role of educator for the doctors and nurses. How do you work with that, Jordan?
It's also a difficult one. We see it a lot in a hospital setting just because there's so many different people, right? Everybody has their own things going on. Everybody has their own biases. Everybody has their own opinions of things. And again, it's really just advocating for the family. We did have an incident where in Jamaica culture, the discipline is very different than it is here in Jamaica. It's stricter. Smacking a child is not, uncommon in Jamaica. So when Leah was asked, is mom strict or what disciplinary measures does she use? She said, well, she will smack my arm or she will hit me from behind, and never hard, never leaving a mark or anything like that. But we had a large discussion of, is this abuse or is this allowed? What do we do with this? And that was a really hard situation to navigate, to understand that, culturally it's different in Jamaica versus what it is here. And we have to look at that. It never happened here in America, didn't happen over at the Ronald McDonald House, never happened in the hospital. We never saw it. Mom was very good with her from, everything that we saw, but the discipline is different and we have to understand that and to be able to advocate that, we have to look at this seriously, but we also have to take culture considerations as well.
To honor that culture. Another attendee asks, how did you receive a referral for a patient needing service in Jamaica, and who reached out to you about her condition?
So our transplant surgeons actually train the surgeons in Jamaica. We have that connection. So I think one of the surgeons in Jamaica that underwent that training with our surgeon reached out and had said, this is way out of my scope. She's declining very quickly. She's going to need more than what we can offer here. They don't do pediatric transplant surgeries, if at all. So he had asked, would there be any opportunity for us to do it here in America with that surgeon that he had already had that rapport with? So that's how that initial referral came in. At that point, the surgeon reached out. We have a transplant team. I was a part of the transplant team at that time. So we all kind of got the referral all at once and fell into our roles and started working.
Got it. All right. So it looks like I'm not seeing any other questions in the chat, and it's about 10:05. I'm just trying to monitor time too, but it looks like any other comments, Jordan? Anything else that you'd like to tell us about this particular client and her family and all of the dynamics? Anything stand out to you as something that's above and beyond sort of what you talked about in your slide deck presentation?
I think I really grasped it. There was, like I said, there were so many things in between that had happened or that you don't really think of, like working with a travel agent. I was like, who does the hospital work with and how do we build that? And who do I contact? It's just working through things and being like, well, I never thought of that. The cell phone bill, when mom was in Jamaica to call up here, that takes a lot of money to do an international call. So working through all of that, who pays for that, who does that, and just different things like that. So just things that, there's things in between that we don't really realize until we're doing it. And then we just kind of do it. We just get through it.
Very social worker-y of you to say.
Yeah.
Well, Jordan, thank you so much. I think I'm imagining that folks are going to have a few more questions for you when we reach our 10:40 time later in the hour. So I am going to thank you so much. I'm very proud of you. And I'm going to turn this over to Chris and Chris Bradbury and Chris's colleague, Dr. Sherelle Lockhart.
Hello, can everybody hear me okay?
Yes.
Okay, so now I just need to figure out how to do the sharing of sound. Here we go. I think I'm good. All right. Okay. Alrighty. Well, thank you guys for having us today. My name is Chris Bradbury. I am a recreational therapist and child life specialist. and I worked as a team lead in disaster relief for Hurricane Dorian. I'm joined here today by Dr. Sherelle Lockhart, who was incredible in our entire experience there. And we are going to talk about our collaboration after the hurricane. So let's get started. First, I just want to tell you a little bit about my role as a child life specialist, because not that many people know what we do. And kind of how that all came to fruition. So I'm a certified child life specialist. Our specialty lies in the effects of trauma on the development of children. It's not the same for everyone, but there is kind of a scale that we use to kind of predict behaviors and kind of results for kids who have been through trauma. We are most often found in hospital settings, as Jordan mentioned, and we collaborate with other allied health professionals to reduce the effects of trauma wherever we can. This can look, a lot of times it's through education, whether that's procedural education, diagnostic education, going to the OR, can be helping with procedural support, caregiver support, emotional expression, lots of different ways that we can help. And we're branching out into different settings as well. One of those settings happens to be disaster relief. And so I worked as a volunteer with Child Life Disaster Relief, and they deploy child life specialists to support children in as many disasters as possible, which they could be man-made, they could be natural disasters. It's completely volunteer-based, and we have to have a child life certification and disaster-specific trainings to participate. So. Can you guys still hear me?
I can still hear you, yes.
Oh, you can, okay. All right, so we just wanted to show you a quick little video about kind of just the background of the hurricane, just so you know what we're talking about. So let me know if you can hear this. Give me a thumbs up if you can hear the music. A moment. So now that you know a bit more about what we were dealing with, I want to talk briefly about what the importance is of child-specific support after a disaster like this. It comes down to a study that was done between Kaiser Permanente and the CDC many years ago, and the idea of adverse events, childhood events, was brought up. And it turns out that these adverse childhood events can have a massive impact on our future as adults and our function. So just a few facts here. Adverse childhood experiences are potentially traumatic events. They could be happening once, they could happen many times, they could be natural or man-made, and all of this is happening before the age of 18 while our brains are still developing. These stressors can impact everything from brain development to our immune systems, our stress responses, which then impact our attention, our learning capability, all sorts of different things. It is very much a domino effect. back when this was done, 64% of adults in the US said that they had experienced at least one ACE in their childhood, and 17.3% of them had experienced 4 or more. This was done in 1998. So if you can imagine how many more possibilities for adverse events that children could be experiencing these days, it's kind of mind-blowing. The studies show that, of course, it is most prevalent in females and minority communities, and all of this has shown to have effect on generational trauma, access to education, socioeconomic status, mental health, and physical health. And wait for this, this is absolutely mind-blowing, but mental and physical health costs associated with the ACAs, this is back in 1998 again, were $748 billion annually between the US, Canada, and Bermuda. That is a massive number. And it just goes to show all of this information, the absolute domino effect that it can have. So what do we want to do? We want to prevent this pattern from developing, if at all possible. But how do we do this? This is a US-based study mostly, except for Bermuda and Canada. How does this translate to different cultural implications in a completely different country? We know that trauma looks very similar because we go back to our survival mode, right? Fight, flight, freeze, or sleep. So we know that looks very similar no matter where we are in the world. But what do the cultural components look like as a result? To share more about how this kind of came into our work, Dr. Lockhart is going to share some information with us.
Good morning, everybody. So just a little bit about the Bahamas. We are an archipelago, which is a chain of islands made up of more than 700 islands and keys. Only 30 are inhabited, but the majority of the population are on New Providence, which is the island that houses our capital city, Nassau, as well as Abaco and Grand Bahama. 2 of those densely populated islands took a direct hit from catastrophic Category 5 Hurricane Dorian. We saw this storm coming days in advance, and our Prime Minister at the time begged people to evacuate the low-lying areas of both of these islands. However, living in Hurricane Alley all their lives, many took for granted the possible devastation that this storm could bring. The Bahamas' National Emergency Management Agency, or NEMA, was already poised to begin its rapid assessment exercise of the worst hit areas. Because of the layout of our islands, they could only be accessed by helicopter and boat, as the airports were underwater. Thankfully, one of the telecommunications companies was able to maintain contact with the mainland, and some of the smaller keys had satellite phones. So I'm a general pediatrician, and I know nothing about disaster medicine, but my involvement came just because I was at the right place at the right time. I connected with one of my pediatric colleagues in Grand Bahama who had set up a command center at her home, distributing food to her neighbors and assessing their need for water and supplies. There was no electricity, and only a minority of people had generators. The second connection was one of my associate physicians from my office who had been recruited by our Ministry of Health to go to Abaco during the initial assessment to help care for injured children. Of course, she took along formula, diapers, and medical supplies. Best of all, though, was our Deputy Chief of Staff, a pediatric emergency medicine trained physician who reached out for our assistance in connecting with the international organizations who pledged their support and to help locate children with the most urgent need. This is where we connected with the CLDR and me with Chris. There were many social considerations when taking care of families, mostly from Abaco, who were displaced to New Providence. Many from Grand Bahama fled to the US. We had to firstly connect with them as family islanders, having come to the big city. Abaco had 2 large shanty towns that housed what we believe were thousands of undocumented immigrants. These areas were completely destroyed in the storm, as the structures that were built there did not even meet code for the mildest of storms. They had no running water or legal electricity. They were afraid, and a lot of the parents of the children we treated did not even speak English well. It was oftentimes difficult to get accurate medical information. Our country is largely a Christian nation who believe in Jesus Christ. And when disaster strikes in any form, they look to the Bible and verses like Psalm 121. I will look to the hills from whence cometh my help. My help cometh from the Lord who made heaven and earth. They rely on faith to see brighter days ahead. So very similar to our previous presentation about punishment and discipline in Jamaica, we are very similar to that. So corporal punishment is definitely the usual mode of discipline. Spare the rod, spoil the child. In our modern pediatric practice, we discourage this, but it is still widely accepted in most communities, and even more so on our family islands. It is quite common practice for older siblings to be in charge of the younger ones with babysitting duties. Despite being sensitized about differently abled, there is still a lack of resources to assist, and there are not always proper accommodations for people with disabilities. During the aftermath of Dorian, this was compounded even more in the overcrowded shelters across New Providence. Now, when it comes to gender roles, there is still the overriding thought, the man is the head of the household. Our relatively small LGBTQ+ communities still seem very afraid to come forward to seek assistance, medical or otherwise. They are still mostly in the shadows of society, but we tried really hard to identify and address the needs that were brought to our attention. So collaboration. There were many moving parts, and communication was truly key. Things were certainly not perfect, but there were so many people that pitched in to help that even the situations that didn't work as planned were still able to benefit people who were hurting and just looking for the human connection. The work at CLDR was so rewarding. The sites were predetermined, and once the team arrived, they were quickly able to assess the numbers of children and quickly work to make them feel comfortable and to build rapport. Of course, their parents also had to be put at ease in that they would come out of these sessions with renewed confidence, joy, and faith. Their smiles told it all. The resilience of children is unmatched and warmed my heart every day. I received hugs, high fives, and thumbs up on a daily basis, which was priceless. The sites identified included the shelters, schools, our pediatric medical clinic, orphanages, the emergency youth hostel, museums, and of course, the church.
So from our perspective in Child Life Disaster Relief, there were 4 teams of us that we each deployed for 1 week. But before we could do this, it was a very stringent process of getting approval from the Ministry of Health, which Dr. Lockhart absolutely had that up. And once we had our approval letters, we could get going with all of the logistics on our end, most of which were taken care of by CLDR, including flights, accommodation, drivers, and supplies. Every day we would go assess the needs at each of these sites and feed back to Dr. Lockhart what we felt the needs were in terms of the kids and if we needed to continue to go support in those locations. We had daily debriefs among ourselves and with the organization itself to make sure that we were practicing self-care and that we were planning well for the next days. We had reports for the Ministry of Health as well as CLDR. And we all, basically it was communication frenzy. It was just constantly back and forth, and we just couldn't have done it without Dr. Lockhart. In addition to Dr. Lockhart, we also interacted with a lot of the shelter personnel. There was AmeriCares there was Red Cross there. And so kind of identifying our roles to them where we were kind of new and they didn't know what we were doing, that was an important process as well. So within disaster relief, what were our objectives? Why was it so important? We know from the ACEs why it was so important, but how do we help that? So we know that the inability to take effective action is what makes trauma trauma. So keeping that in mind, we wanted to assess children and meet them where we are. We did not want to assume anything or place any preconceived notions on them. And I'm going to explain a few stories in a minute that will illustrate how wildly different they thought about this process. We used a lot of child-directed play to assess them and also to be careful about cultural components of our care. Child-directed play basically gives a little bit of structure and a little bit of support and allows the child to express through play in any way they desire, as long as it's safe for them. So that was a really great tool for us in terms of our assessment. So what can we do? We can help them understand that adults are doing something to help. We can find small ways to give them control and give them something to do to help. We might talk with them about the future, or even talk and debrief with them about what they've been through. We can teach and model regulation and coping skills and social skills that might have kind of gone out the window because we're not really thinking about those things when we're in survival mode. We try and help establish a safe base for emotional expression, where sometimes the kids were just so worried about the emotions of their parents that they didn't feel like they could go to them and express their own emotions. They thought their parents were already going through too much. And we helped them gain a sense of mastery and control in whatever way we could. So I'm going to read a few examples here about, and I'm going to start with these pictures here and move on to the next slide, but you can see this one with the rainbow and the lightning and the thunder. One of the participants said, "This thunderstorm is my heart and how I feel right now because of the hurricane. The water below is changing colors. It's showing that change is coming. The rainbow is my promise that the change will be good." So that was her kind of expressing her hopefulness through her artwork. And then you see these other pieces of artwork here. One of the children drew the beginning of the hurricane, where he saw the trees starting to bend in the wind. Another drew himself in the water during the storm and spoke of his fear when he was on the boat. He drew sharks and said while he didn't see any, the other children said they were there and it scared him. Another girl took a white piece of paper and vigorously covered almost all of it black. She was unable to articulate what it meant. It's a good starting point, and we just want them to be able to express themselves wherever they can. So I'm not going to read through this. You guys are welcome to read through. These are just a list of things that we help with, including procedures with Dr. Lockhart. A lot of kids needed their vaccinations so that they could enlist in school. Group support, child-directed play, lots of different things. So a few things about these photos here. We have this young lady up here holding a book, and it's an emotion book. It's about identifying our emotions, and here she is acting out what it means to be angry. And a lot of kids went through these books and they just picked out how they felt in those moments. And again, it was just a way of them putting a word to what they were going through. On the left here, the boy who was playing with the emergency vehicles was processing how he felt about his emergency service, what they did with him. So how he was rescued, his experience on the boat. And the interesting thing here was there were people who were all in the same boat, and there were children who had a harder time with it, like the boy who was worried about sharks. And then there were kids who were younger who were talking about it like it was a Disney cruise where they got all this food and they got to play and they got to just roll with the sea, and it was really fun. So that's why we don't ever want to assign a preconceived notion about what they might be going through, and we would let them express to us through play. Here in the playground, we have a young group who is playing Duck, Duck, Goose. This was an attempt at helping with the community feeling, because a lot of the kids, after losing everything, were very kind of grabby and understandably protective about the things that they owned. And so whenever we would do group play, it could get sometimes a little bit intense and a little bit violent. And so how do we work through that? We gave them opportunities to do cooperative play. And in this specific example, you can see a boy in a white shirt on the right. He actually had an intellectual disability, and his mother said to us, "Oh no, he can't play." One of the things we like to do is try to have inclusion in all of our activities. And so we brought him out and we showed the other children how he could be included in play. And 3 days later, they were independently getting him and taking him to the playground so that they could include him in play. And it was a great community building opportunity for them. Further below that, you have a man who is playing with the chalk. We were initially using this with the kids, but a community member came over and said, "Hey, can I do that too?" And he's clearly an artist, he's very talented, and he's drew the rest of the community around him who just wanted to watch him draw. And it was a moment for them where they were telling him, hey, draw my house. This is what it looks like. Or, hey, can you draw these mountains? This is what they looked like. And they're all reminiscing, and another opportunity for community as well. And then the bottom left one is medical play, which is one thing that we do all the time to help normalize medical procedures for kids and get them prepared for seeing equipment and things that they might have used on their bodies when they are having checkups and vaccinations and things like this. So these are just some of the ways, some of the stories that we have, and hopefully illustrates kind of the importance of, even though we're not fixing anything, we're starting that process of looking up and giving that opportunity to work through those difficult emotions and those difficult experiences, and then looking toward the future.
So 4 years later, we are still recovering. There was so much to overcome in these large communities affected. Firstly, the loss of life was unimaginable, and the inaccuracies of the reports cut very deep for so many. They lost family, friends, and neighbors, yet these numbers were not officially counted. People whose relatives remained missing, which means nobody found, are not considered dead by law until 7 years have passed. Therefore, life insurance payouts have been greatly delayed. We are just now getting banks back onto Abaco so that people had easy access to cash. So many who had owned homes before have had to leave their communities and rent in other communities, or are still living with family members in New Providence. Then came COVID-19 in 2020, which eventually shut down the entire country. Movement was very restricted, and so the forward movement of rebuilding stalled and then stopped. Children struggled in new schools and then had to go on to virtual schooling. Many parents preferred to move to other family islands rather than have their children go to school in New Providence. However, many people are still helping. We have the Red Cross, we have Habitat for Humanity helping people to rebuild their homes. We have UNICEF, of course, the religious communities, and our local NGOs. Then finally, a little plug about climate change. Our islands have a low elevation, only a few feet above sea level. They consist of Swiss cheese-like limestone, which allows salt water to permeate through. So water comes in from beneath and all around the sides as sea level rises. Stronger and stronger storms can form as the waters get warmer each year. We're hoping to gain partnerships in slowing climate change from the larger countries. Reduce, reuse, repair, and recycle. Thank you.
Thank you all for your attention. Here are some resources, and we welcome your questions.
Thank you both so much. And we are going to be uploading our recording and our slides and your slides to our YouTube site and our Epic website. So yeah, so I'm sure that people have questions about this disaster relief initiative, this team-based care that happened in kind of the face of chaos. I've got some questions, but I'm looking to the chat to see if there are folks that want to get ahead of me. All right, so thank you, Wendy. Wendy also put into the chat a link for the resources. So I guess a first question would go to you, Dr. Lockhart. So as a medical professional and a resident, what were some of the thoughts that were going through your head as the storm was happening in your home? When did you start preparing for the worst, and what did that look like?
So I think, again, the same kind of thought as everybody else. We could handle this storm. We've gone through multiple storms before. It's going to be good. We're going to be fine. And I think the issue came when the storm stalled. So it stalled over those islands for more than 24 hours with winds of 185 miles an hour. And I mean, no structure is built to withstand that. And so when we realized that the storm was going like at 0 miles per hour, and saw videos coming in from people we knew who were sending like WhatsApps and things as to what the storm was doing around them, while they still had communication, I think that's when my brain really went into, oh my God, this is actually happening. And even though it didn't happen to New Providence and we seemed fine and we were great, our family and friends were going through the worst time of their lives. And so that's when my brain really kicked into gear and I was like, okay, we got to start setting up a command center basically. And that's what we did in our office, my private office, for pediatrics specifically, but really for anybody that needed help. My colleagues in Grand Bahama, we sent them clothes, we sent them because they basically lost everything. And they were in the hospital over the time that the storm was happening, the emergency room folk. They had to evacuate parts of the hospital. They put patients on like the floaties that you have in a pool to float them out of the hospital. So our hospital in Grand Bahama was completely devastated. And they went through some trauma, even our colleagues. And so just to try to help them get through so that they could help the wider community is what my focus was initially. And then of course, for all the kids.
Wow. And it makes sense, your reference to climate change, is something that I think people are aware of, but there's also this sort of lulled sense of, yes, we've endured this. Yes, this is, the umpteenth time that we've gotten notification that this big storm is on its way. But we can think about places in the United States too, where that's, it's still true. How prepared are people for these massive storms that literally, as you said, it's going to tear down a structure if those wind, if the miles per hour of the wind is that high. So there's another question. How different is it working on an impromptu temporary emergency integrated care team versus working on something that's more, settled and permanent? Sort of this like, let's cobble this together. This is going to be out of my home, or, what's your experience?
I had none before that. So that really, it just came together because of all of the international help that we had. Yes, we did try to do things amongst ourselves and what we could from New Providence to the other islands, but really our international help was absolutely key and life-saving. And really it was just the communication, trying to figure out who would be the best fit and when they should come in. Should they come in right after this disaster, or should they come in 2 or 3 months down the line when their skills and their help would be more needed? So we definitely went through that very detailed as to who should come and when they should come.
And I guess I'm curious too, like, did people pay attention to your timeline, stay away when you needed to kind of just sort of get grounded in your communities? Like, was that an honored kind of timeline? Is something?
Well, it kind of had to be, just because of, the geographics of it. People couldn't just come in. They had to get approvals, they had to get visas, they had to get, there was a lot of red tape for people to be able to come in and offer help. And it's not that we didn't want the help. We just wanted to make sure that the right people were coming in at the right time. So I think they had to honor our timeline.
And Chris, how did you become involved? Like, tell us about, your kind of entry point and the timing in this, in this disaster, in this hurricane.
Yeah, it was unusual, I think. So I currently live in Spain, and I happened to be in the US for a conference. During that conference, one of my friends who is also a child life specialist told me about child life disaster relief. And at the time, I didn't know about the hurricane yet. We knew that it was coming, but no one knew what the impact would be yet. But there was rumor that they might try to implement some support if it did come through, and the support was needed. So I signed up and got in touch, and it just so happened that they needed the help. And so I actually went straight from that conference to the Bahamas to help out with that. And I've been fortunate to be involved since then, and it has grown immensely since then. It's amazing how many people you can get to volunteer when, you know, the purpose is genuinely to help kids get through these things. So it's been very impactful to have this experience and be involved with CLDR, and to have been able to go do what we do in the Bahamas.
And so are you sort of like on this kind of a wait list for deployment, like continually? Like, is this something that you're always, you know,
Yeah.
ready?
So they actually have local community ones as well. So unfortunately, for example, if there is a mass shooting event, they have child life specialists who can deploy there. If there are hurricanes, so they usually try and use more local people. And so they will just call whoever they can, and they'll send out emails to say, hey, who's available for this? Recently they did one for as a like an anniversary for a school shooting, and so they had, you know, there were pet therapy there were child life specialists, and it was for the whole community as well. So they really try to do a lot of assistance, whether it is in the moment or, you know, somewhat after.
Thank you. And I'm looking at the chat. How about other questions for our colleagues? Other questions? So I just have a couple more for Dr. Lockhart. So Dr. Lockhart, how did you navigate the kind of the two realities of being a survivor and a responder kind of simultaneously?
So I'm not sure I did that well. I think I went into responder mode. And even now, as we were doing this presentation, I told Chris, you know, I haven't thought about this in eons. We just did it. It was like adrenaline. We did what we had to do, and I haven't gone through it in my mind until now. So really it's something that I kind of push behind, and something that I realize I probably have to work through some more, being a survivor. Because I think being in New Providence, I just thought to myself, it's not me. I'm not going through this. It's my family and friends who lost their homes, and family and friends. And so I really never thought of myself as having gone through very much.
And like you said, that adrenaline kicked in and you were in that kind of do mode. And, you know, I guess, you know, another question is sort of, how has the outlook of Bahamians, I don't know if I'm saying that right, changed regarding hurricanes since Dorian? Or do you think it's sort of that default, you know, kind of hitting back to that sort of lull of, you know, this was a one-time thing, and I'm not sure, did we lose?
I think we might have lost her. I'm not sure. She froze.
Okay. She was freezing a little bit earlier. So and Chris, I don't know if you can address that question. And if not, that's okay.
Yeah, we actually talked about this. And so, you know, what she had told me was that it was a really big kind of jolt of realization that, you know what, it is a big deal. And so people are now ready. People are ready. She said that people on Grand Bahama, most of them went mainland US, and now people are ready at the first sign of a storm to get on a plane, because they know that, you know, plane access might not be available if the storm actually comes through. And there's obviously a lot of trauma there. She said that some people have had to move away from the island because it's just too a rainstorm, normal rainstorm is just so traumatic, and it brings up too much. And so there's been a lot of lives changed, but I think people take things much more seriously now, and they're ready. And I don't know if I have a second to address what you had asked before about kind of what's the difference between, doing an emergency disaster relief versus, your normal interdisciplinary team. I would absolutely say that it is, it's absolutely chaotic. It's exhausting. It's sad. There's a lot of emotions. But one of the things that I really loved was that, there didn't seem to be as much ego. Everyone was very genuinely invested in the same thing, and we were all on the same level. And it made it easier to do our jobs once our roles were established. It was difficult because we didn't necessarily know each other's communication styles or culture necessarily. And so we had to give a lot of grace for that, but it was still a wonderful experience from that perspective. There she is. She's back. Dr. Lockhart, there you are.
I'm sorry. I froze on computer, so I had to
Okay.
come on my phone. I apologize.
No, it's all good. This is the world we're navigating these days, and it's all good. So we were talking about sort of how the outlook of Bahamians has changed regarding Hurricane Dorian, and I think Chris was addressing that, but I'm also noticing that we're at sort of that open Q&A time right now. So, I think we're all so super interested in this disaster relief, and especially across the stories that we've heard this morning, I'm hearing, how important it is to sort of push that ego down. When you've got a team, these big teams that I'm thinking about too, are, it's especially critical, I guess, to kind of take that out of as best you can, take it sort of out of the pot a little bit. But how about for our other presenters, Jordan, Dr. White, Dr. Wenger, other questions that you've been sort of holding on to that you'd like to ask? These are really different constellations of people that have come together and worked for the greater good, for better outcomes for children, adolescents, transitional aged youth, that population that we're focused on, and really interesting collaborations and stories. What questions do you have for our presenters this morning?
So one of the things I wanted to ask was all three presentations really focused on communication. And so I would love to ask the five of you kind of just each speak to one takeaway that you would have about opening up that communication or continuing that communication or overcoming communication barriers amongst the team members that you're working with. If you could each just kind of give one big takeaway. I mean, I guess that's the best way to ask the question, please.
I'm going to popcorn it to Dr. White because there's I see so many squares, and I'm just trying to figure out.
No problem. And Dr. Wenger, you can unmute too. There are two things, and I know this comes from my therapeutic lens that I do to get over the hump of communication barriers when working with teams. And the first thing is start off with validation. Right. So that kind of relieves people's defenses. So I might say something like, oh, you're right. I never thought of it that way, even though I might be countering that point. Or I might say that makes real sense to me. Or I might say, so this is what I'm hearing you saying. Is that correct? Right. So these are things that I use in my clinical space often. But then other times I, as Julie echoed earlier, am quite a bully. And I'm like, I come in strong and say, wait a minute, no, we're not doing that because of A, B, C, and D. And so what's next, right? Because sometimes you just have to, shut some stuff down as we move forward. What do you think, Dr. Wenger?
Yeah, I think that balancing of being very direct and very clear, so nobody should wonder what I'm thinking after I've communicated with them. They should understand where I'm coming from, what I'm thinking, and why. But then pairing that with an invitation to listen, and pairing that with, support and collegiality. I can tell, I mean, Dr. White and I haven't actually known each other all that long, but we both kind of like come in hot with the honesty, and we just bonded immediately. But I mean, I think that just goes to show how, if you're just clear and honest, like you can get to know somebody so quickly, you understand where the other person's coming from, you can disagree with each other, right? And having that comfort and trust so that somebody can come in and disagree with you and be like, we're not doing that, this is why, and you can sit there and hear that without, being flustered and getting inside your own head. So while you can't necessarily expect the person on the other side of communication to receive what you're saying well, I think you can go in with your skilled delivery and bring your skill also to how you receive information. And, that's the best that you can do. The rest of it's kind of on the other person.
I think both of you said it so nicely too. And I think what I have learned is that the way that we come into a conversation sets the tone for the entire thing. I've had nurses come to me and be like, well, this physician isn't listening to me because X, Y, and Z. And it's like, well, how did you start the conversation? Did you start off defensively? Because they're going to put their defenses back. But I think we can do a whole entire segment on communication and how to communicate. Especially in a healthcare setting, things are moving fast. People are always on the run. Time is of the essence, and we really need to make sure that what we're communicating is honest and in a time-friendly way for people to really understand that. But I also think on the other side, we need to be open-minded too, to be able to help open conversations and have conversations and difficult conversations.
I could chime right back in really, really quickly. I would say also it's important to close the loop. And so if I'm having a verbal meeting or a conversation with someone, I tend to send an email after saying, okay, so this is the plan, this is what was discussed, so that we all have it laid out.
I feel like all of those are so good. And I prefer direct, communication. I think sometimes when I'm feeling like things are getting a little out of control and I have ADHD, so I have to remind myself not to be so sensitive sometimes. And I have to kind of go in and say, hey, let's start over. This is the style I use for communication. And I want you, don't think anything of it if I'm this way. This is just how I am. How are you? What do you like for communication? And that's when it's already kind of escalated a little bit, but kind of starting with what everyone else has said is usually kind of a go-to. And just openness about everything.
I can add one more thing to that, because this is something I say to my students, and we happen to be in fall discussing this right now. But, in terms of that feedback receptiveness and the whole idea of feedback and giving, critical feedback to people, I try to offer like a reframing, because I feel like many students report discomfort receiving feedback, especially when the feedback is, redirecting or what they perceive to be critical. So I try to offer a reframing where if somebody has sat down and spent the time to really digest what you're doing, what you're saying, to digest your work and have thought through everything that you're doing and saying and putting together feedback for you, that's extremely effortful, and that their attempts to help you grow, like to be able to reframe that feedback as caring, as opposed to criticism when someone's really taking the time to give you that detailed feedback. And so I try to frame that for my students, but I also try to keep that in my head as well.
Other questions for our panelists, for our presenters this morning? Okay.
Just add thing.
Please.
So for me, I think it's just respecting each other, respecting each other's expertise, respecting their time, their availability. So I'm a big proponent of, being on time, and for the most part, doing what I say I'm going to do, and respecting people's time and their wishes. And so that's how I go about starting the whole communication process. If I tell you that I'm gonna WhatsApp you at whatever time or call you, that is really what I tried to do as best as possible, because we had so many people who were foreign to the Bahamas. They didn't know where they were. They didn't know how they were going to get one place to the other. So I tried to be that kind of stopgap. If something didn't go right, that they could call me anytime and for anything. And so I just tried to be as open as possible. And again, we're all on the same level. We all have the same goal in mind. And so that really was the key to the communication.
Your word is your bond. Thank you, Dr. Lockhart. All right, I think that is going to do it for us this morning, except for the post-test. So I just want to thank you to all of our panelists. You have enriched us with your stories of collaboration and teamwork, with all of your examples. And we are so grateful for your time and grateful for the attention of our audience members. Thank you for coming this morning. I am going to share the slide that has the QR code. And in the chat box, you will see the post-test link. Thank you, Sarah. So the post-test link is in the chat, and you can also take the post-test by taking a picture of the QR code or scanning the QR code.
I don't see the link in the chat. Ah, there it is.
All right, we're going to stay on until 11 o'clock, but it looks like the link is in the chat. The QR code is still on the screen. And if you need to leave, thank you again for coming. This concludes our symposium. If you've already taken the post-test, have a wonderful day.